pretty quickly. As I said, the indices and scoring is going to be gone over in more depth when you're in community health, but we touched on this already. You are going to be using indices and scoring on each and every one of your patients, right? And you need to be familiar with these. You don't need to memorize all of them, but they're in categories that we want you to kind of clump together to get the feel of it. So let's go on to the types of scoring. Okay, when do you use scoring? Okay, for individual assessment scores, that's what you were doing in private practice, right? You're taking a plaque index, you're taking a bleeding index. For perio, you're doing other things for that particular patient. But these scoring methods are also used for clinical trials, on epidemiological surveys, and community surveillance. All right, so when you're doing a whole community project and you want to know, you're doing scoring for the prevalence of tooth decay in a certain population. Okay, so that's what you're using there. So an individual assessment might be more detailed than something that you're using for other methods. Clinical trials, it's very important that you have calibration within the people using it. It's important for all of them, but go through the textbook in chapter 21 and just get a feel for what these are. All right, because this is community health. I will not be asking you questions on this. All right, but indices. Okay, what are the general categories? All right, we have simple indexes, and they measure the presence or absence of a condition. Is there inflammation? Is there not? Is there bleeding? Is there not? Is there biofilm? Is there not?
I'm sorry, I can only see the title page.
Oh, here we go again. I did it. I'm going to stop this share. Thank you for letting me know. Okay, can you see biofilm scores here, or did I pull up the wrong one?
We can see.
Okay, all right. There was a little there when I'm sharing a screen, there is a green square around it, and there was a green square. So do you see the indices slide now?
Yes.
Okay, thank you for letting me know. Okay, so you've got your general categories. There are simple and cumulative indices. All right, so a simple is going to be simple. It's going to be fast, easy, checking one thing. Cumulative, you're looking at more than one thing. All right, but what is the selection criteria for anything? For anything, it needs to be simple to use and simple to calculate. It needs to be using minimum equipment and be inexpensive. All right, so you might only have one instrument or a mirror and a probe or a tongue depressor, something like that. It uses minimal amount of time because you're doing this on multiple people. It doesn't have any discomfort for the patient. It has clear-cut criteria, right, that anybody can come in and it will be calibrated. So it's free from possible subjective interpretation. It's there or it's not. And if it's there, sometimes you have to record how much is there. And it needs to be reproducible by the same examiner or different examiners, right? So that means when you're going through statistical analysis, which I hate statistics, okay, that it has validity and reliability. Okay. Now, when I was taking statistics in graduate school, I am so poor in math. The instructor just didn't put an X there and say it was wrong. He said it was completely wrong, as in I was clueless. He was putting adjectives on the X because we had to show our work. That was quite embarrassing, but I got through somehow. I don't know how, because you can see how I'm not really a numbers person. All right, so we've got our simple or cumulative, okay? And we've got our selection criteria: inexpensive, doesn't hurt the patient, reproducible. So a lot of that makes sense, right? So let's get into the different types of indices. We've got oral hygiene status. We've got the biofilm, debris, and calculus. All of that can be assessed. So for the biofilm index, that's to assess the thickness of the biofilm at the gingival area. Now you're using a disclosing solution on every patient. Are you doing a biofilm index on every patient? Yeah, you are. And biofilm index is the same, Katya, as the plaque index, but we're not calling it plaque anymore. Okay, we're calling it biofilm because we know that it's more of a complex matrix and everything else, but we just haven't caught up with the name. So, okay, it historically was known as the plaque index. All right, so if you're seeing a P, you're going, if it's asking you is for what is this indice measure or P, it's either going to be perio or it's going to be plaque. So you look for answers that have one of those words in it to help. Okay, but the biofilm index is the thickness at the gingival margin. So you've got specific areas to examine. The facial, for example, is divided up into 4 areas. And they also have modified procedures, which have 3 areas instead of 4. So you have to know which index you're using. But you dry the teeth, you evaluate the dental biofilm, and how much is it. You're using a probe or something to try and scrape it. You pass the probe or the explorer along the tooth surface. You use a disclosing agent. Most of these indices, the lower the number, like a 0 is good and a 4 is bad. Okay, just like anything else. A 0, there's nothing, and a 4 is it's all covered. So we have our a 0 is no biofilm, and for the plaque index, the biofilm index, it actually goes to 1, 2, and 3. Okay, 3 is getting towards that materia alba, that really thick stuff. So you need to know what is being scored and how the scoring is. So your office is going to, for example, have their own index that they use. We do a biofilm, a plaque index, right? And we don't use this particular one, but we also add a description. How thick is it? Okay, generalized cervical, thick, slight, dark purple, what's the color, the consistency, because the darker the color of the disclosant, the older that biofilm is. This is looking familiar to you, and this is the score that we use. This is one of the many biofilm control records. And we've got these little slips of paper that we cut up because we used to, when we had paper charts, we kept a biofilm index. So if they came in 6 times, you'd have 6 of these on one page. So you'd be able to see how they're going. Hopefully they're getting less and less and less. But this looks at all of the teeth. Okay, it looks at all of the teeth, and what you're doing is you're coloring in here, you're coloring in, let me see if I can do that. So, there's biofilm here, 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 and you're just going through and coloring in. And then what you're doing is you are adding all of these up. So this has a potential of 4 sites per tooth. So it's the number of tooth parts with biofilm. All right. And then 4 times the number of teeth present. So if they've got 32 teeth present, it's 4 times 32. And that gives you the bottom number, and that comes up with a percent. All right, so it's simple to do. What we didn't have the ability to do with Dentrix is put this on the Dentrix chart. So what you're going to find when you're at that part of your process of care is it's going to start with tooth number 1 and go all the way down to tooth number 32. And you are just typing in, entering in mesial, facial, lingual. Okay, mesial, distal, facial, lingual on each tooth. And then you're adding all of them up and doing the math. Okay, and you're dividing it and timesing it by 100 to give you the percent. Right, so that's what you incorporate with your patient. All right, you are always doing this with your patient and letting them know what you're finding. You have a plaque index of 76% today. That means 76% out of all of your tooth surfaces have biofilm on them, right? Studies have shown, or whatever, that we're trying to get everybody down to 10% or less, because if you're 10% or less, that means you've got control over the amount of biofilm, and the teeth and the gum tissues have a better chance of getting healthy, staying healthy, that type of stuff. So then they come back after you work with your OHE, and they come back and you do this again, and you say, wow, you were 76% last time, and today you're at 32%. That's fabulous. Or you were 76 last time and you're 88 today. What's going on? Did you even brush? I mean, we don't say it like that, but that's what we mean. All right, you're getting the patient involved. And when we go over the OHE skill evaluation, the patient's going to want to get involved because you're asking them for their short-term goals. You had a plaque index of 76% or a biofilm index of 76%. What do you think a reasonable reduction in biofilm next time will be? Oh, I want to get it under 10%. Well, that might not be reasonable. So why don't we take it to, let's half it, let's make it 40%. Okay, and if it's less, that's even better. All right, so you're incorporating the patients into those numbers. And this is what second year fails to do, is they wait until the patient's gone to get this biofilm score done, the percent, and they will get a U big time if they get caught. Okay, do not be lazy with this, because this is an integral part of your patient education. Do you do this in private practice? No. Do I do it? Did I do it? Yes, I did this because I worked in perio. Did I disclose my patients? Yes. When I was in general practice, all my kids got disclosed. Did I do a plaque index? No, but I did a description. Generalized, slight, cervical, blah, 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 heavy, at. I didn't take a number, all right, but I did a description. So each office is going to be a little bit different, but this is what we use. Biofilm-Free Score. All right, so you're looking at erupted teeth. You use disclosing solution. You give the patient a mirror, because this is all part of the process. And then you're diagramming also. All right, so you've got a biofilm-free score and a papillary bleeding on probing score as well. So if you're calculating the percentage for one quadrant, do we still multiply it by 4? Yes, but your quadrant might only be 8 teeth. So it'd be 8 times 4 instead of 32 times 4. All right, so this is another one. I have never seen this one. Biofilm-Free Score, never seen it. Patient hygiene performance along the similar lines. All right, we're looking at biofilm. Low score versus high score. Where is it? How thick is it? No debris, some debris, okay, on each and every tooth, or it could be a simplified, and that has the S on it, and that means you're only using specific teeth. You're not doing all 32 erupted teeth. Simplified oral hygiene index, all right? So the simplified might be using tooth number 3, 8, 14, 19, 24, 30. So one will be on the facial and the maxillary will be on the facial and the mandibular will be on the lingual. Somebody's trying to come in. Thank you. So simplified, all right? Number 3, number 8, number 26, I'm sorry, number 14 on the facial, then 19, 24, and 30 are on the lingual. That's all you look at. Doesn't matter what all the other teeth look like. How much? Okay, so 0, slight, moderate, heavy. You can do it for calculus as well as for plaque or biofilm. So the simplified takes very specific teeth. So if there's a 0 for calculus, there's no calculus, versus a 3, oy vey. So I want you to get a feel for these, all right? There's gingival and periodontal health indices as well. How much is inflammation is there? How much bleeding, right? Is it just the papillary bleeding? Is it marginal? Is it diffuse bleeding? How much, how fast does the bleeding happen? Sometimes there's delayed bleeding. So we want to record that. You're going along, checking things, and then you're going back after you do 2 or 3 more teeth and you're looking to see if there's any bleeding that is oozing, okay? Because spontaneous bleeding means there's a lot more inflammation than delayed bleeding. So periodontal screening and recording, this is from the World Health Organization. The boards do ask you about periodontal screening and recording. This is using a separate probe, a very distinct probe, all right, and it's got a little ball at the end, so it doesn't hurt the patient, all right? And then there is a silver line, a black line, and silver line again. So this black line starts at 3.5 millimeters and goes to 5.5 millimeters. So what you're doing is you're probing each and every tooth, but you're not writing everything down. Each sextant has one code, and you're taking the worst code for that sextant. And that code would be 0, 1, 2, 3, or 4. All right, so a 0 is the black is not even in sight. Code 1, all right, you're just at the black band. Code 2, all right, the black band, but you can still see some of it. All right, and then codes 3 and 4 are the deeper areas. You're not seeing any of the black band, or there's attachment loss, visible recession. So what the World Health Organization was doing, this is how you screen a lot of people. Then the American Academy of Periodontology decided that this is what we should be doing in private practice, because offices were getting sued. One of the main things they were getting sued on was failure to diagnose periodontal disease. Well, we don't have time. We don't have time. So do a PSR on everybody. So they had little stickers and let me see. And I don't see a picture of the stickers here. Okay, so they had little stickers, and it's in the book, and we would put down 1, 2, 3, or 4. And if you had a 3 or a 4, that meant you took that sextant and you did a complete perio charting. Instead of doing it full mouth on everybody, you just did the sites that were had disease. So if they had 0s and 1s, but then one sextant had a 3, you'd only have to do a comprehensive on that particular sextant. I work in perio. I couldn't stand it. My last office I was in was general practice. It's like, no, 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 we're not doing this. I want to know if 4 mesial is bleeding each and every time. Not that there's just one bleeding point, but I want to know that it's 4 mesial so I can investigate to see, is there an overhanging or plaque retentive surface? Is there residual calculus? That type of thing. But the American Academy of Periodontology said, this is better than nothing. So we were doing this for a number of years. Now the AAP is saying this really isn't adequate. Every patient should have a comprehensive periodontal assessment. So we're getting away from that, but the PSR, periodontal screening and recording, again, is from the World Health Organization. They have done it to now fit into private practice, and private practices are still using this. It's better than nothing. You can take 2 minutes to do this and get a feel for what the whole mouth is. So some patients will come in, and some schools will have the patient come in first, and you'll screen them. You'll use a PSR to screen them. You'll see if there's any medical consultations that are needed. Then you'll do an EO-IO, and then you'll do a PSR. And you will get a rough estimate on their perio status, their difficulty level, what type of radiographs do they need, and then that patient will then be assigned to a student. And some schools are still doing it that way. We used to, but that was also involving an extra appointment for the patient. So we found that there really isn't any different than just have the patient come in. So periodontal screening and recording. Community, periodontal index, community, guess what? You're looking at a larger population. This is the PSR, codes 0, 1, 2, 3, 4, and there's a little asterisk there too. So does it cover the black? Okay, if it's going into the black, you know it's more than 3.5 millimeters. If it covers the black, you know it's more than 5.5 millimeters. So this is just giving you a guesstimate. Sulcus bleeding index. You've got 4 gingival units that are scored. So you're walking the probe along and you're looking at specific areas of the tooth and you're waiting for 30 seconds. All right, some are going to bleed spontaneously and some will ooze a little bit. So depending on how fast it bleeds and how much it bleeds, that's your score. Sulcular bleeding index. Okay, the 0 means it's healthy, a 5, gusher, spontaneous bleeding. Then you've got your bleeding index that you can do per area, per tooth, or per individual. All right, so it really depends on what you're using it for. you are doing a bleeding index for the entire mouth. You're getting a percentage. So you're doing the same thing. If you have 6 probe readings per tooth, you're multiplying the number of teeth that you probed by 6. All right, because you've got the potential of 6 areas of bleeding. So unlike the plaque index that you're using, the biofilm index, where you're multiplying it by 4, the bleeding index, you're multiplying it by 6 because that's the number of readings. And there's different ways to determine this. Eastman Interdental Bleeding Index is one. This is where you take a stimulant and you push this in 4 times, 1, 2, 3, 4, and you see if you get any bleeding. Don't use that anymore, but the boards go over that. Your gingival index. Okay, we're still looking at periodontal health here. You've got 4 areas. You can modify the procedure, but you dry off the area. You use a probe to press on the gingiva to determine the degree of firmness. All right, how edematous is that tissue? All right, how puffy is it? So the gingival index. Dental caries index. What you need to know about this is, all right, the permanent dentition uses capital letters. DMF, decayed, missing, filled. DMF. Primary teeth uses lowercase letters. DEF, decayed, extracted, or filled. So lowercase, deciduous, uppercase, permanent. And then you can figure out what it's trying to do by looking at the letters. Decayed, missing, filled, DMF, lowercase. So if you had a uppercase DMFT, what would that be for adult or second permanent teeth or deciduous?
Permanent?
Permanent.
It would be permanent. Yeah, permanent. It's uppercase. All right, so there's also DMFS for surfaces versus teeth, which is more specific. So DMFT is for the number of teeth. So if it's got 1 surface on it or 4 surfaces on it, it still goes to that DMFT, versus DMFS is looking more specifically at the surfaces. Early childhood caries is still prevalent in all areas of the world. So you are looking at that. That's why we encourage parents to bring in the siblings of the younger siblings of kids that are getting their teeth cleaned, so we can take a look. Okay, we're educating the parents before the baby is even born about proper nutrition, and we don't want the bugs that are in your mouth being transferred to the bugs that are going to develop into your baby's mouth, because that bacteria is going to set up residence. So if the mother and father or the primary caregivers don't have healthy mouths, you don't want them introducing that bacteria into that child's mouth, because some people don't have strep mutans. If they don't have strep mutans, their likelihood of getting tooth decay is a lot less. So we're educating the patient all the time. Root caries. Root caries, the nice thing is, guess what? For root caries, there's going to have an R in there. Did I have a test question on that for some of you last semester? Okay, if there's an R, You're going, I've never heard of that before. You look at the choices. Is it going to be a gingival bleeding index? Is it going to be a plaque index, a bleeding index, or is it going to be a root caries index if you're seeing an RCI for your index? Dental fluorosis, we got into last semester. All of these have different scores as well. Is it just a little or is it a lot? Are they just white spots or is it mottled enamel? Dental fluorosis, and there's a number of these indexes. And we don't need to get into that. So the World Health Organization is where we get a lot of our science from with epidemiology and how prevalent certain conditions of the mouth are. Okay, it's from these whole big population studies. And they have to be consistent, they have to be quick, they have to be inexpensive, and they have to be tolerable to the patient, and they have to be reproducible as well. So ASTDD, I have never, ever seen that one. Association of State and Territorial Dental Directors Basic Screening Survey Criteria. I have never even seen any questions on this one. I will not ask you. ASTDD. So again, ASTDD. You look at what these might stand for when you have a multiple choice question. You're marking down the index or indice that you used. You are writing down the percent. And then you are interpreting, making an interpretation. So if their bleeding index was 32%, but it was localized to the maxillary left quadrant, there was spontaneous bleeding or minimal bleeding, you're making a description. Because spontaneous bleeding means there's a whole lot more information than if it's just a little oozing 3 teeth back, okay, when you go back and look. So you're explaining all of this to your patient, and you're having follow-up instructions, okay? This is where most of the inflammation, and we don't use really inflammation when it comes to patients. We want to use the word infection because they can understand that better than you've got a little bit of inflammation here. You have a little bit of bone loss. No, you have infection, you have bone loss. It's not just a little bit of bone loss because things just don't happen overnight. So you're documenting what you explained to the patient, what pamphlets you gave them, and what you'd like them to do. Okay, any questions on indices? I hope
have a
that helped
question.
a little bit.
Yeah, thank you, Ms. D. It helped a lot. I have a question
Of
about
course.
the root caries index. So the calculation is a little bit different than the others. Do we need to remember and know the calculation for the root caries index too?
Absolutely not.
Thank you.
You just need to know what it's used for. And if it's a small number or a large number, what does that indicate?
Okay, so what is the F stands for in the root caries index?
The F, I don't know.
Okay.
So, how's that? I don't know. But if you find out, why don't you, you can text it to everybody.
So in the other calculation, the F stands for filling, right? Or filled?
Decayed, missing, filled, yes.
Yes. But in this one,
DMF.
I was a little bit confused. What is this? Does it
And then
mean?
DMFT, DMFS, tooth or surface.
Yes.
Okay. So let's take a quick break because I've been yakking for an hour. Let's take a quick break. We'll come back in 5 minutes and we'll get on with what we had on the agenda today. Oops. Don't make me move.
Talk about a year, not real.
Okay, let's come on back. This is where we're getting into the real nitty gritty of what we're doing. We're going to talk about oral infection control, which is the new way of saying brushing and flossing, right? And when we're talking flossing, we're talking interdental cleaning. And one thing that has really changed over the last couple of years is flossing is not the only thing the patient can do to clean in between the teeth. In fact, flossing might be one of the more ineffective ways to clean in between the teeth. What did I just say? Oh my gosh, did she really say that? Yes, we're getting away from flossing. What are we using instead? Water picks or water flossers. Exactly, Amy. Because what they've discovered, and we'll get into that in the next chapter, is that flossing only gets 2-3 maybe millimeters underneath the gum tissue. Flossing is only effective if you have a type 1 embrasure space. If you have a type 2 or a type 3 embrasure space, flossing is not going to be effective. So you need something else, a tufted end floss, a Proxibrush, something else. So we're really getting away from flossing being the end all of everything. Okay. And we are going to be spending some time in clinic also reviewing the various brushing techniques and how to demonstrate them and how to go through your OHE skill evaluation and what you need to do in order to succeed with that one. And you will be doing an OHE skill evaluation on each and every semester that you're in. And why are we so concerned about this OHE skill evaluation and what you're doing? Because let me tell you, this is the most important thing we can do for our patients. What we do, our scaling and polishing and everything else that we're doing for our patient is only good for 24 hours. And then the biofilm comes back, right? And then after 24 hours, then it turns into 72 hours, and you've got all of this maturing biofilm. So unless we can teach our patient how to control their mouth, how to control the bacteria in their mouth on a daily basis, we have failed. So this is the most important thing we can do for our patients, to be able to have them go and on a daily basis disrupt things. So you are dealing with patients that will only brush once a day, and you're dealing with patients that will brush 12 times a day. Is one better than the other? Not necessarily, because the brusher that's doing 12 times a day might be irritating the gingiva and causing recession, versus the 1 time a day, if they're doing a really good job, might be all they need. As long as you are disrupting that bacteria within a 24-hour period of time, that's all they really need to do. But if you save it up for 24 hours, you've got a boatload of stuff to try and disrupt, and your technique has to be pretty spot on. So it's better to break it up twice a day or 3 times a day, whatever the patient can do, because you only have half the amount of biofilm accumulation, and you're massaging the gum tissues twice as much, so you're exercising a little bit more, and you have more of a chance of maybe getting something you missed the first time on the second time. So sometimes more is better, but more can be too much as well. All right, so we have to go over, all right, I'm not going to go over the origins of the toothbrush, but we do have a sample of them when we go over this. But the early toothbrushes were horse bristles. There were evidence of toothbrushes as early as 3500 BC, and they were chew sticks. And some areas of the world still use chew sticks. And guess what? They can be very effective. And depending on where that chew stick is taken from, some of these chew sticks actually have antimicrobial properties in them. The sanguineous root is where used to be used on these chew sticks, and studies were showing that, wow, these particular people had very little decay, very little periodontal disease. And why? Well, they went to go see what was in that chew stick, and they were using the sanguinaria root. So then the American people in Europe started taking that sanguinaria and making a rinse and a toothpaste out of it to try and get those chemicals to a broader population. It turns your cuspidor red. I didn't like it, but you did it. So anyway, toothbrushes and cleaning teeth have been around since the beginning of time. Used to be horse bristles and boar's hair. The idea of that, though, is that it was very difficult to have a consistent soft, medium, hard brush. You had whatever the thickness of the hair was, and hair is hollow in the center. So it was really more of a bacterial trap than anything. But wild boar was used also, and synthetic materials weren't being used until after World War II. Now we're using power brushes, and power brushes started coming in around the 1960s, and they've come in fashion, out of fashion, in fashion, out of fashion. Now they are back in fashion, just as the water pick is. All right, so you need to know the different parts of a toothbrush, okay? Just like the different parts of an instrument. Okay, parts are parts. You've got your handle and your head of the toothbrush. You have tufts of the bristles or filaments. You need to know what the length of the filament is here, because the length of it determines also how flexible that filament is going to be. You want to know the width, because the thinner the brush is, the more likely the patient can get into hard to reach areas. Think about the mandibular anterior on the lingual surface. Think about trying to get to the distobuccal of tooth number 16. All right, they can't use a big fat brush there. But bristle or filament height, 11 millimeters. That's the recommended. That's on your boards, 11 millimeters. It will be on your test. Somehow you will get a question on filament height. You want the toothbrush to be easy to grip. You want a rounded head so it's not poking, okay, and not jabbing. You would like this to be slip proof because some hands get sloppy. And now they're making these handles very wide also, which is making it easier to grip. So this is the classic toothbrush, flat brushing plane. But they come in all sorts of different sizes and shapes now. So the flat was the classic. Look at this rippled. I like the rippled. When you're doing your little wiggles, it gets interproximally a little bit better. Butler has a great brush that has these tiny little hair, like thin filaments coming out that gets subgingivally a little bit better. And look at the curve here, okay? Butler, this is indicative. Butler made this one famous. Then you've got the multi-level, which is a take on the rippled. You've got the angled. They go in all sorts of different directions. And some of these angled are thicker and thinner depending on the make of the toothbrush. And then you've got your bi-level orthodontic brush. So there's lots of choices out there. You go to the oral hygiene section of the grocery store, Walmart, Walgreens, wherever you do your shopping, it's impossible for patients to make an informed decision. So I always made sure that I gave the patient what they could find. I mean, some of these toothbrushes you can only get through your dental office or through Amazon. I didn't like that aspect of it. I wanted them to be able to go to Walmart and find it to replace it. We want end rounded filaments, okay, versus the jagged. Okay. Oral-B was the first one to come up with the end rounded filaments. They're kinder to the gingiva. Power toothbrushes have come and gone. You have your Oral-B. You will be getting your Sonicare. She's coming to talk to you, I forget when, early February. Sometime we're having a webinar, but you'll be able to get your Sonicare, and I want you to use both of them so you can tell the patient what you're recommending and why. Because some patients might be better off using the Oral-B round brush versus others the Sonicare, right? And you need to know the difference and why. Patients are going to ask you, should I be using an electric toothbrush? 9 times out of 10, you're going to be saying yes, because it does a more effective job if you're using it correctly. But if they've got pristine oral health, would they really get any benefit of it? No. Do they like gadgets? Yes. Okay, they're brushing, they're flossing, they don't have any biofilm, their plaque score is like 3%, and their bleeding index is 2%. Do they need it? No. Would they benefit from it? Can't hurt. And there's all sorts of different price points as well. So all of these toothbrushes, all of the companies make toothbrushes at the $20 level, the $10 level, or the $200 level. But basically, if you have a patient with difficult to reach areas, if they're bleeding, if they have biofilm, they would benefit from a power toothbrush. And we're calling them power brushes instead of electric brushes because they're rechargeable batteries, they're not plugged in, and it's just more descriptive with the power brush. But they know what, patients know what an electric toothbrush is. Right, and they have different motions, different speeds. Some of these companies will have different brush heads that the patient can choose from. And some will just have small and large. So this is from the 80s. It was called the Interplaque, and this is the toothbrush that allowed science, they had science behind them that brought power brushes back into favor. Before it was like, don't waste your money. Okay, they had these tufts, and each tuft rotated in a different direction, which was really cool. So this one would rotate this way, and this one would rotate that way. And it did a really nice job. They had long bristles, very long bristles, and they would, like a mop, they would really get into the interproximal areas quite well. So when I was working in perio and they had these type 3 embrasure spaces, this was a terrific brush for them to use. So that was one of the first ones. The problem was each one of these tufts had a gear in them, and each gear could get clogged up. But they make brushes like this, manual brushes too. They make, this is a, each tuft is separated. So the older brushes would look like this. Now you're finding everything is closely and densely packed. This is the Oral-B brush. They come in different sizes. The nice thing with the Oral-B is they have color indicators, and you can see for the pediatric, there's more space in between those circles. All right, so it's softer, and it's got this blue. Oral-B was the first one to have these blue indicator lines. And what that did was it showed you when that blue was starting to decrease, it showed you when that toothbrush needed to be replaced. When the blue went halfway down, when the color was half gone, it was time to replace the brush head. So you can see from the pediatric, it's shorter and it has less tufts in it. I have a sister-in-law with a very small mouth. She likes the pediatric brush. And the world is divided up into two sanctions. You're an Oral-B user or you're a Sonicare user. And with the Sonicare, there's also those bursts and other sonic toothbrushes out there. I'm an Oral-B user. I have short little chiclet teeth and it fits my mouth perfectly. So I use Oral-B. I've been using it for the power brush. I've been using it for 35 years. So how do you select a toothbrush, right? You have toothbrushes in your instrument kit that you purchased. Next year in the fall, you will also be gifted more toothbrushes from Johnson & Johnson. They have the Reach toothbrush as well as other flosses and rinses and those type of things, because we want you to customize what you're giving to your patient. We're not calling them goodie bags anymore, and you're not pre-filling the goodie bags and just handing them out willy-nilly. You're customizing, you're choosing this brush because you're choosing or recommending this floss because, and Johnson & Johnson will give you different types of floss to use. Now you've got Glide, which I personally do not like, but that was for the price point, that was the best price point. And patients like Glide because it doesn't shred and you don't get pieces of floss stuck in between your teeth. For a non-flosser, Glide is a good introductory dental floss. What's in your kit that you use on your patients is a Johnson & Johnson floss, which has some of the newer technology in that I love. So you're trying to individualize things for your patient. Why are you choosing this? I'd recommend a tufted floss here. I'd recommend this there. I'd recommend this type of toothbrush for you because, right, patients like a stiff brush. They like a large brush because they think that they can just go one swipe whoop, and they've got it all. Well, if it's working for them, it might be okay, but generally the smaller the brush, the better, because you can really get into the sulcular area and around crowded teeth. Say on the mandibular anterior, you need a small brush to get in there. So you need to know the different types of brushing methods because you will be watching your patient brush. And then you have to mark that down. What brushing method are they using? And there's names for them. Okay. And then what are you modifying their technique to do? Is it going to be the Bass or modified Bass? Is it going to be the Stillmans or modified Stillmans? What are you showing them? So when I get that patient the next time and you saw them and you went over the modified Stillman, I know what they should be doing while I'm looking at their technique. Does that make sense? So the Bass is the gold standard. Bass, Bass, Bass. We are looking at Bass. That is considered the only sulcular brushing technique. The only sulcular brushing technique. It actually gets the bristles underneath the gum tissue. And then there's the modified Bass as well. So this picture's in your book, but you are trying to direct those bristles underneath the gum tissue to get into the sulcus. So that means you're tilting the brush towards the gums. Now, you're tilting the brush at a 45-degree angle. Do patients know what 45 degrees is? No. So you don't need to incorporate, 45 degrees, blah, blah, blah. What you can do is say, just tilt them towards the gum, just a little bit. And for the Bass, you're making little wiggles. You're not moving off the tooth. You're only moving that brush about half of a tooth width. Wiggle, 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 wiggle. You count to 10 real fast. That lets the patient know how long they're supposed to be there. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Next area. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Next area. How high do they count up to? 10. Do they need to count each and every time they brush? No, but that just gives them a feel for how long counting 10 does. Now with the power brushes, it's got a timer. So it lets them know, you know, you should spend this amount of time on this quadrant and then you go to another quadrant. Okay, because it should take about 2 minutes to brush your teeth. So you're angling towards the brush, towards the gums, you're making little wiggles back and forth, not long wiggles, and you're counting to 10. On the anterior area, you are holding the brush parallel to, again, try and get those bristles subgingivally and wiggling still. It's kind of a tiny little back and forth or a tiny little circle. So if you're watching your patient brush, and if they're doing circles, that's fine. You don't have to tell them they have to go back and forth if they're a circle person. If they can do tiny little circles, again, what you're trying to do is shimmy those bristles underneath the gum tissue. So that's the BAS. The modified BAS is you're wiggling to 10, and then you're doing a rolling stroke. So you're wiggle, wiggle, wiggle to 10, and then you roll it. Wiggle, wiggle, wiggle to 10, and then you roll it. Okay, but the thing I don't like about the modified techniques is it's incorporating too many things. So they're wiggling to 10, they do one roll, and then they get to go to a new area. And I don't think one roll is going to get through a lot of biofilm. I like the BAS method. So I will teach the BAS method, and then the patient can go in and do whatever they want. Because brushing is one of those things where we're thinking about what we're doing for the day and what chapters are we going over and that type of stuff. So I find, this is me, I find let's concentrate on the gum line area first. And then if they want to do circles, if they want to do a rolling stroke, they can do whatever they want. But I don't find one rolling stroke really effective. So the BAS is wiggling 45-degree angle. The modified is wiggling with a rolling stroke. Now the Stillman is different from the BAS. It's not really considered a sulcular brushing technique, but look at where the Stillman's is. And the Stillman's, you start perpendicular or parallel, okay, versus the BAS, you're angling. So for the Stillman's, you are starting like this, and then you're rolling the brush to where most of the bristles are on the gum tissue. Then you're doing your wiggle. And if you're doing a modified, it's a modified if you're doing the roll. But look at this palatal. See, it's not concentrating on trying to get the bristles underneath the gum tissue. So the Stillman's really isn't the best technique. Now, it's really great if they've got recession and other things, but what is the patient going to do to get underneath that sulcus? The BAS technique. Then there's the rolling stroke. Older folks learn that. Brush in the direction that your teeth grow. So Stillman is going towards the gum. There's something called charters, which goes towards the occlusal surface. When would you use the charters method? Do you see an advantage of ever teaching that? And the answer is yes. Think about your patient. Yeah, think about your patient who has ortho. They have to do the Bass technique to get this way. They have to do the Charters to get this way, and then they have to brush underneath. So they're really doing 3 different brushing techniques to do a thorough job. They do have ortho brushes where there is, it's cupped out. That doesn't do quite as thorough of a job, but for ortho patients, they're using the Charters method. Think about if you have open embrasure spaces. Also, when you don't have necessarily a Proxibrush, all right? Think about if you've had periodontal surgery and you need to stay away from the sulcus area. You're using the Charters method. But Charters is usually used for ortho. Horizontal or scrubbing, big back and forth. If they're doing big back and forth, you don't have a whole lot of modifying to do to get them to do the Bass. Big back and forth is they're doing from number 2 to number 6. 1, 2, 3, 4, 5, and they're just scrubbing back and forth. What you want them to do is angle the brush and do little wiggles, okay? Instead of the big back and forth, you're trying to shimmy those bristles. So I use my hands when I talk to the patients, and when I do the scrubbing method, I'm taking my hands and going from the left to the right, you know, woo, woo, versus wiggling and shimmying. I'm using my hand and just making tiny little shaky motions, and you want those bristles to be shimmied in between the teeth. So if they're using the scrubbing method, they just need to slow down a little bit. Scrubbing method is great for all the teeth as long as they don't have recession and they're not causing any damage, but you need something to disrupt that biofilm at the gingival margin and right below. Circular method, phones, and I remember being a student, phones, okay, is circular, round, okay, oh, all right. Circular method, this is what we teach little kids. They go in circles. They are biting down and they're doing top teeth and bottom teeth at the same time. They don't have the dexterity. So they're using the phones technique. Now there's something in your clinic help that has a whole page of what these different toothbrushing techniques look like. Phones, oh. Leonards or vertical. I haven't seen any anything on the Leonards or vertical ever. Power brushing. We recommend it. The idea of the power brushing is the brush does the work. So the patient holds the brush in one spot. Now, when you're doing your wiggles for the Stillmans and the Bass, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, for the power brush, they place it at the proper angle and they just hold it there for a count of 3. 1, 2, 3. 1, 2, 3, because the power brush is going to do the work and shimmy underneath the gum tissue and between the teeth. Don't forget about brushing the occlusal surfaces. Little wiggles, not big horizontal strokes. Again, those little wiggles get into those pits and fissures. Brushing difficult to reach areas. Sometimes they need to hold their mouth open. Sometimes they need to hold their mouth closed in order to loosen up that cheek, especially if they've got third molars, maxillary third molars, close down just a little bit, loosen up that cheek. You'll work with the patient with that. Occlusal brushing, back and forth, they're tiny little circles. You're trying to get into the pits and fissures, areas that need special attention. Sometimes you're holding the brush completely different. Okay, so occlusal brushing. So you can see that they're trying to get the toothbrush around the distal of the terminal molar. So for this, they're holding the brush out. So they have to have looser cheeks to reach there. So that means they have to close down just a little bit more. Sometimes the different types of toothbrushes too, for these, that's where the head of the brush will have longer bristles to reach around that. There's also end tuft brushes. Okay, but look at this. This is a specialized brushing technique for the vertical position on the maxillary teeth. Now you hold the brush like this for the mandibular anterior, but if they've got crowding on the maxillary, sometimes that's the only way to get into a particular tooth. What type of embrasure space is this? Type 1? It's a type 2. Yep, and then type 3 would be blunted. Tongue cleaning. Some offices are even doing tongue detoxification and charging money for it. But the tongue, because it's rough, it's got all those nooks and crannies, it's like a shag carpet, retains so much bacteria that it's important that the patient brush their tongue. It's been shown that tongue scrapers do a more effective job than tongue brushing. Some offices will even detoxify and use the ultrasonic scaler on the tongue. Has anybody seen that done? It feels really, really weird. Okay, but the whole idea is you want to remove as much of the bacteria as possible. So everybody should be cleaning their tongue as far back as they can get. And there's all sorts of different types of tongue cleaners. I used to have a little tooth mug on my counter, and I would collect tongue scrapers and just have an array of them to show patients. My favorite one is a little plastic one that you're going to get with your Sonicare that you fold, and it's got ridges on it, but they make metal ones as well with ridges or a smooth. The ridges work better. Some patients are gaggers and can't get back very far. Okay, if you've got a gagger, the gag reflex is less at night. So you can have the patient try it at night to brush their tongue or to scrape their tongue. Scrapers have been shown to get more posterior than brushes. Okay, so it's more effective with a tongue scraper. We'll get into this as far as sequencing and everything else. Duration of brushing is typically about 2 minutes. The power brushes have built-in timers. Some of the manual brushes will, the handles will change color for the kid brushes. And when the handle changes color and it's from the heat of the hand, then they know that they're in there long enough. But some of these smart kids know, and they'll just put the brush underneath hot water. We used to have little egg timers that we would give out, like little sand dials, and then they'd flip it over, and that would be their indication. I like the count system better, because if they're there for 2 minutes, that's fine, but are they using that 2 minutes effectively and getting everywhere they need to be? They could be daydreaming and spending 2 minutes in one spot. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, new spot. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's what I find. Okay, the newer toothbrushes have these mobile applications. They've got apps that you can have on your smartphone to tell you where you're brushing, where you're placing too much pressure, where you're missing. They're getting very, very smart with these Bluetooth things. The power brushes also tell you when you're placing too much pressure. Too much pressure makes the brush less effective as those bristles splay. They're not getting to where they need to go. And too much pressure can also irritate the gums, creating gingival recession. So they've got lights on the power brushes, and to let you know, or the patient know, that they're placing too much pressure. We do have test drives, Oral-B test drives in the clinic, where It's a sealed toothbrush with disposable brush heads. So it's a very clean way to instruct your patients, especially if they have an Oral-B power brush at home. They don't need to bring it with them. But it's always good if you're doing OHE to ask what the patient's using. Are they using an electric toothbrush or a power brush or manual brush before you even start? Because if they're just using an electric toothbrush and you're spending a half hour instructing them on how to use a manual brush, it's just not going to sink in. Have them bring their toothbrush. So when the patient has acute inflammation, right, it's going to hurt when they brush. They're going to bleed. They could have traumatic lesions already in the mouth. You don't want them to continue to scratch them. So they have extra soft brushes, post-surgical brushes, as well as those little foam sponges that the patient can dip with chlorhexidine and gently wipe those areas. Chlorhexidine is a chemical that kills bacterial plaque, biofilm. Okay, so it's chemically debriding and not physically. Okay, following periodontal surgery, post-surgery bristle brushes are very, very soft, and you don't want to irritate where the sutures are. Following dental extractions, again, you don't want to disrupt where that blood clot is. That blood clot comes out, they have a dry socket. Boy, is that painful. What is a neutropenic patient? Okay, this is towards the end of the chapter. A neutropenic patient. Neutrophils, are they white blood cells or red blood cells?
White.
White, yeah. So neutropenia is a low white blood cell count. So that could occur with patients that are undergoing chemotherapy, radiotherapy, bone marrow transplants, other cancers, okay, or neutropenic patients. When they're undergoing treatment, especially cancer treatments, they end up with a host of oral conditions. And Mrs. Bashan is going to be doing in April 24th. It's a Thursday. I'll have a sign-up sheet, but she's having a 2-hour CE, which will be virtual, on treating the cancer patient, because they are special patients. And you'll have a whole chapter on this next year. But there's mucositis, and that's inflammation and ulceration of the mucous membranes. It's hard to undergo chemotherapy without getting mucositis. Then there's changes in taste. Fungal and viral infections can take hold. Trismus, which is difficulty in opening. There's a lot of pain, especially if they've got the mucositis. So you need to know what to recommend for your patients, and you don't want them to make matters worse by using things that have a lot of alcohol in them and those type of things. So there's a lot of support groups and a lot of places that you can get recommendations from. If the patient's got extremely dry mouth, for example, the Sjogren's Association has a lot of recommendations for those patients that you can go on site and get recommendations for them. Patients might need a topical anesthetic. There's something called magic mouthwash that the pharmacy makes that has milk of magnesia and liquid lidocaine and other things to swish with to help numb the area so that the patient can take care of their mouth and actually eat also, because eating is problematic if their mouth hurts. Fluoride recommendations, especially if they're having radiation in the head and neck area, do they need a fluoride tray, which is similar to a whitening tray, but they have fluoride in it. adverse effects, there's toothbrush abrasions, there's hard tissue lesions they can have. They can actually, especially around the CEJ, where that enamel and root surface, the CE is so thin, that CEJ area, they can actually abrade those and cause toothbrush abrasion. Soft tissue lesions, they can scratch, they can tear the gum. If you are using a hard bristle brush and you're scrubbing, you might not have sores in your mouth, but that's going to irritate the gums to the point where the gums are going to say, hey, I don't like this. I'm moving, and they go away. The gum tissue disappears and they have recession. Anytime the patient brushes, there is a bacteremia that is being induced, right? If there's any bleeding, whether you see it or not, it could happen in the sulcus as well. So we are actually disinfecting their mouth. Let's swish with, if they're neutropenic, they might need to swish with something first, like we do with the pre-procedural mouth rinse. Okay, reduces the bacteremia, but it can also help loosen up the biofilm as well. Patients can't forget that they need to take care of their brushes. Ideally, they are keeping the toothbrush out. It's not going into the medicine cabinet. It's out in the air so it can dry completely. You don't want that warm, dark, moist, all right? It needs to dry completely. So it is recommended that you have a morning brush and a nighttime brush. I do, but I use my power brush in the morning and a manual at night. That's just my thing. They need to know also when to replace it. The ADA, American Dental Association, is recommending replacement of the brushes every 3 months. But it's anytime those bristles start changing shape, anytime those bristles start splaying. And if it splays too soon, that means they're scrubbing and they're putting too much pressure on the toothbrush. But every 2 to 3 months, change the toothbrush after a cold, after you have a herpetic lesion, after you have a virus of any kind. Change your toothbrush or disinfect your brush. Some patients will put their toothbrush in the dishwasher and use the sanitizing cycle for that. Some will soak it in peroxide. Some will soak it in mouthwash. Okay, but the toothbrushes need to be clean. You want to make sure that all the toothpaste is off of them. Also, toothbrushes do become contaminated from not only your mouth, but if you've got a cup where the whole family's putting their toothbrushes in, not good. If you've got the cup close to the bathroom toilet, not good, unless, you know, close the toilet seat, because that there is an invisible plume when you flush the toilet of aerosols that you can't see coming up from the toilet. Ew. Are you going to die from it? No, but aesthetically, cosmetically, just the thought of it, ew. All right, so that's why toilet seats have covers. All right, so it's best to keep the toothbrush away from the toilet. You want light. Some of these toothbrushes, Sonicare used to have a UV light that you would put the head in. They don't sell that one anymore, but there are other UV brush sanitizers that you can purchase as well to try and keep things sanitized. But brush replacement is important. And I kind of got ahead of myself there. Any questions on toothbrushing? I have used up our time. So that means I did not get into interdental cleaning, oral infection, interdental cleaning. We are going to have a clinic session that deals with interdental cleaning. And the important thing is on that one, I'm just going to take 1 minute to go over that, if I can. I'm not going to keep you, although the got my wrong PowerPoints up. Let's see. Interdental. Okay, let's see if I can get this up. We're going to go through this real quickly. Can you see chapter 27? Can you see learning objectives?
Yes.
Okay. So we don't really need to go over the anatomy of the interdental area and the proximal tooth surfaces because you know that, right? You've got the gingival embrasure. So the whole idea is you want to clean in between the teeth and get down to the caul area with whatever you're doing. So you are doing a caries risk assessment. You're asking them what are they using to clean in between their teeth. All of that is before you even take a look in their mouth. How many times a day are they brushing? All right, brushing does not get in between the teeth effectively. The power brushes have been known to get underneath the gum tissue deeper than a manual brush and interproximally more than what manual brushing can do. So you've got patients with all sorts of different needs. This is interdental brushes. This is called a Proxibrush. Gold standard here is a Proxibrush. You have a reusable handle with different brush types. So what was interesting was last year, somebody did their article critique on a study that was showing this. I always liked the Christmas tree shape, but this was the brush. The cylinder shape was shown to be more effective than the Christmas tree brush. Floored me. My common sense was saying this one was, but what do I know? But the study showed this one was. So they come in different shapes. This is a really big one. So you put the brush, little brush on here and you attach it. And these are replacement. These are we call travel brushes that have a little cover on them and the neck here bends. And these are go-betweens, which is what you've got in your kit also. You've got these go-betweens and they are silicone or rubber with these tiny little teeth on them, which clean in between the teeth. It's better than a toothpick. So these are more portable. But the interdental brushes, look at what the in-between portion of a tooth looks like. Flossing doesn't get that, but a brush can. If you have recession, okay, look at what that floss has to get versus a brush can get in there very nicely. This is a stimulent. Now these stimulants are made out of balsa wood or some sort of soft wood that you get soggy and it's got a little squishy factor to them. They also make those triangular toothpicks in plastic. There's different types of floss. So review them. You want to make sure that the patient isn't snapping the floss down. Okay, you want to seesaw the floss, make a C or a horseshoe, scrape up and down 1, 2, 3, come up over the papilla, scrape in the other air section 1, 2, 3. Okay, most patients just snap in and snap out. Floss threaders, there's all sorts of different ways to get underneath hard to reach areas or pontics. You have floss threaders. Okay, you'll need them for flossing underneath braces, and you'll need them for flossing underneath bridges. Tufted floss, Superfloss is a name brand. Thornton's is another name brand. So you can use tufted floss for larger embrasures. One end has these are individual strands that like to get all knotted up in the bag, but it has a floss threader here, which I've never liked the tufts, and then a piece of really ropey type of dental floss, which I don't like, but the Tuft is nice. And Thornton's is nice because it has different types and different sizes of tufts. Do they need just a little bit of fuzz, or do they need a big piece of fuzz? Floss holders, you're going to be getting some next year. Johnson & Johnson has a great one, the Reach floss holder. I can't tell you how many patients I've converted to flossing because of those things. Fingers, yes, they're better because you can really make that C or horseshoe. Some patients don't like putting their hands in their mouth. Some don't have the dexterity. So floss holders are a good alternative. For areas that have large spaces, you could even use a piece of gauze. Okay, but what you want to do for the floss holder, this is one of the older ones. Okay, it's got a long piece here that you are manually wrapping around, and that piece of floss is very tight, and you seesaw it in, you bring it in, and then you push against this side of the tooth, come up over the gum and push against that side of the tooth. So it's, you're trying to get it on each side, but you can't really form a C or a horseshoe. And on this bottom here, if they push too hard, you're going to have a Stillman's cleft created. These gauze strips are great, or even baby yarn is good for areas where they don't have interproximals. They can shoe shine that area. Power flossers. Water flossers are considered one of the power flossers. Single end tip toothbrushes. I love it. Okay, it's like somebody took a toothbrush and cut it in half. They just have a couple little tufts. And let me see if I can find one. That is going to be, check out page 464. Okay, he has an end tuft. They're great for mandibular anteriors, crowding on the mandibular anteriors, anywhere teeth are out of alignment. They're great for getting around third molars. Toothpick in a holder, the name brand for that is a Perioade. We use this in perio. There is a little handle here with the, this is a knob. You put a round toothpick in and you tighten this up and you break that toothpick off. And you can introduce that toothpick underneath the gum tissue. So you're massaging the gums and you're removing biofilm from underneath the gum tissues. It's great for furcation areas. It's great for furcations. Then you've got your wooden or plastic interdental cleaners. Your Stimudent is a name brand. These are nice because they come in a whole pack that looks kind of like a matchbook, and the patients can leave these in the car. They can put them in their pocket, and it's good if they've got larger embrasure spaces, especially to use after lunch. It gets that broccoli and spinach out. Okay, it massages the facial side of the gum tissue. So they put the flat part of the triangle and they gently press to massage the gums and clean in between the teeth. The problem with this is you can't get in from the linguals. And we're down to water irrigation or water flossers. Sonicare and Waterpick are using water flossers now instead of irrigation. They're great. You can put medicaments into the reservoir. You can, they have special tips called pickpockets. And I don't have a picture of this. Pickpockets, we'll get into that in perio, that you actually have, you angle it towards the gum tissue and you try and get that medicament underneath the gums. So if you've got chlorhexidine or Listerine or something like that, you're actually trying to get that chemical underneath the gum tissues. But your chapter 27 has pictures of those as well. So oral irrigation is great. I recommend it to anybody who's got braces, anybody who has hard to clean teeth. Older patients seem to really like it because they'll brush, they'll floss, then they use that oral irrigator and they are aghast at how much is still coming out into the bathroom sink, what their brushing and flossing missed. but it massages the gums because it has an intermittent spray and it gets in between the teeth beautifully. Okay, that whizzed by. What questions do you have? All right. Well, I apologize. I went through that so fast, but that was chapter 27. It's chapter 26 and chapter 27. Please do read them. They are the foundation of what you are going to be talking to each and every patient about. So that, my friends, is today. Hope you have a good rest of the day.
Thank you, Ms. D.
Thank you.
I have a question, Ms. D,
Yeah.
about the discussion board that we had written already, but I'm confusing about the citation. Do we need the Wilkins citation at the end of our discussion, or just when we at the in between our discussion we refer to Wilkins and that's it?
Well, it all depends on if you used Wilkins. If you didn't use it, you don't need to cite it.
But if we
But if
use
you
it,
had to look up what autonomy was or what maleficence was, if you had to look that up, then whether you Googled it or used Wilkins, you have to cite that.
okay, thank you.
You're welcome.
I had a quick question, actually. The journal, I never got a comment on there.
Who's
So,
your mentor?
Miss Brooke.
Ah, I'll remind her.
Okay. I can send her a message on campus too.
Okay,
Is
she's
that okay to do?
P. Brooks, pbrooks@nvcc.edu.
Okay. Okay. All right.
Yeah,
Thank you.
she's usually pretty good about that. So, but she was with me at the board review this weekend too. So we were texting each other.
Okay. Okay.
Yeah.
Sounds good.
Okay. Thanks.
Thank you.
Any other questions? When is the discussion board due? The first comment, your initial post is due February 4th. Your initial posting is due February 4th. That's going to give everybody in your group until the 11th to respond. Renee's saying February 8th. I got the 4th written down. Initial posting is due February 4th. And then your responses are due by the 11th.
Thank you, Ms. D.
You're welcome. Okay, I'll be seeing some of you. Well, I'll be seeing all of you on Thursday. All right. Bye, guys.
Thank you, Professor.
Online, it says 8. Oh, you're welcome. Okay, I'll check with that one too. You mean the initial posting is you want the initial posting done on the 8th? I'll have to take a look at that. I'll get back to you on that one.